to another EduMed video. This is the first in a series of videos that is essentially meant to be a beginner's guide to intensive care. I'm specifically focusing on junior doctors and those that have not had any airway experience in the past. This talk is on the airway, the endotracheal tube, and it is meant for those people who have not done any anaesthesia or intensive care. Speaking to many of my juniors, often the area of most trepidation is looking after those patients who are intubated. And the reason for this is that there is very little teaching in medical schools or in the first few years of medical practice on looking after these patients who are intubated. So through this talk, what I'll hopefully do is demystify the endotracheal tube and the management of the airway in someone who is already intubated on intensive care. Throughout this talk, what I will do is talk a little bit about the indications for intubation. I think this is important because not every patient on intensive care is intubated. Sometimes we bring patients into intensive care to monitor them and to see whether they do deteriorate, in which case we will intubate them. And therefore, as a junior looking after these patients, it's useful to know what the triggers are for thinking about intubating them so they can escalate to a senior at an appropriate time. I'll also go through the different components of an endotracheal tube and therefore understand what aspects you should know about and therefore what things can potentially go wrong and then how to troubleshoot them. One of the most important things to know about an endotracheal tube is whether it's in the right place, and that'll be a central job for any junior doctor starting in intensive care. I'll talk a little bit about how to assess the intubated patient when they arrive on intensive care. I feel like this is an area that people don't get a lot of teaching on and we pick up through trial and error, but it is useful to have a standard way in which to approach these patients. I'll touch upon the daily assessment of an airway on the ward round and the things that you should always keep in mind to make sure that these patients have a safe airway at all times. Finally, I'll talk a little bit about troubleshooting the problems that can happen with endotracheal tubes that often the intensive care nurses will come to you as the doctor on the unit to sort out. By understanding a little bit about what the problems are, you'll be able to escalate it to the appropriate person and maybe even suggest a solution. So, thinking about why you want to intubate. This is not meant to be a comprehensive list by any means, but I'm just going through some of the more common reasons for intubating a patient. The most obvious, and probably the thing that most people think about when thinking of intensive care patients being intubated, is managing patients with respiratory failure. These are patients who either giving face mask oxygen is not enough to maintain an adequate saturation or partial pressure of oxygen in the blood, or those patients who are developing a type 2 respiratory failure where their carbon dioxide levels are going up and up and up. Similarly, those patients that we think are probably going to end up in respiratory failure who look like they're tiring because they're working hard may need intubation and ventilatory support. The other group of patients for whom it is important to consider intubation are those with a low GCS, i.e. a low conscious level. Now, it's important to understand what we mean by this, because not everyone who has a low conscious level needs intubation, and similarly, some people with a relatively high conscious level may need intubation. What we're really talking about is the protection of the airway. What we mean by protection of the airway is a prevention of aspiration. In URI, if secretions sit at the glottic opening near the vocal cords, it'll stimulate you to cough and therefore to close the vocal cords and prevent those secretions from going down into the lungs and causing an aspiration. In patients who are obtunded and have a reduced level of consciousness, the worry is that they lose their ability to cough and therefore secretions, blood, gastric fluid may drop down into the lungs and cause an aspiration pneumonia, which can be fatal. And therefore, when we talk about securing an airway, what we're talking about is putting in place something that will stop the aspiration of fluids from the oropharynx into the lungs. And therefore, a secure airway is really an airway where there is some way of preventing secretions from dropping down into the lungs. Another group of patients for whom intubation may be required are those who are very agitated. And in patients who are very agitated, sometimes we need to give them a level of sedation that may compromise their ability to protect their airway, but we need to sedate them for the protection of both themselves and for the staff. This is often a decision that is made by a very senior clinician because there are pros and cons to intubating a patient, and therefore it needs to be done in a careful and considered manner. Those patients who have head injuries are also really important to be intubated, and the reason for that is we might need to control their carbon dioxide levels and their oxygen levels. And we will go through that in a little bit more detail in future videos, but suffice to say it is to do with cerebral perfusion and allowing appropriate blood flow to the brain, and therefore preventing cerebral hypoxia and subsequent strokes. Another group of patients for whom we might intubate are those with gross metabolic disturbances. Sometimes you see patients with severe metabolic acidoses who are actually hyperventilating because of the acidosis and trying to correct it. Now again, this is a decision that needs to be made by a very senior clinician, because the moment you take over the ventilation, you may need to match that level of minute ventilation to blow off the carbon dioxide, otherwise the metabolic acidosis might get significantly worse. But again, to control physiology, sometimes by rendering them unconscious and giving them sedation may reduce their metabolic rate and therefore allow you time to treat the underlying problem and therefore allow them to get better. Before we move on, it's worth actually looking at the endotracheal tube so that you understand the different components of it and therefore the different things that could potentially go wrong with an endotracheal tube. An endotracheal tube is a tube that simply sits in the trachea. It is usually put in through the mouth, although you might occasionally see tubes being put through the nose and into the trachea. And you will often see patients with tracheostomies. I will not go through tracheostomies in this video as it's a topic unto itself, and we'll go through that in the next video. An endotracheal tube has a few components to it. You can see that it's a long plastic tube, and often the bit that you see is the bit that hangs out of the mouth with the blue 15mm connector. That is the connector that attaches to the ventilator tubing that allows air to go in and out of the lungs. The tube itself, you can see, has got lines going across it, and that is to mark the length from the end of the endotracheal tube. Now this is important because it allows you an idea of how far into the trachea the tube has gone by looking at the level at the mouth. One of the most important aspects of the endotracheal tube is the cuff. You see that at the end of the cuff, it is a plastic type thin material that fills up with air and forms a seal around the trachea when the tube is sitting in there. This is really important for two reasons. The first is, if you imagine the tube sitting in the trachea, if you blow up the cuff, it provides a barrier between the secretions that sit in the back of the mouth, in the oropharynx, dropping down and going into the lungs. So those secretions will usually sit on top of the cuff. The second important thing is the way in which the ventilator gives gas, air, into the lungs is by producing an increased pressure at the level of the ventilator. Now that pressure gets transmitted through the endotracheal tube, and where we want that pressure to go next is into the lungs to inflate them up like a balloon. If that cuff is not entirely up, the problem is that air might just leak back up around the tube and come out of the mouth. So by having that cuff fully inflated, you prevent that gas from going up and out of the mouth, and all of it will go into the lungs itself. And then similarly, when the pressure releases and the lungs recoil back down, all of the gas comes back out through the ventilator tubing and not through the mouth. Now, the way in which you blow up the cuff is by something called the pilot balloon, and you see that as that blue line that you can see with a one-way spring-loaded valve. You can blow this balloon up by using a 10 ml syringe, and usually between 10 and 20 mils of air is enough to blow up this cuff. The pilot balloon itself is a very useful tool because by feeling it, you can feel the rough amount of pressure in the cuff itself. They're usually synonymous. And if you feel that it's very spongy or very loose or even completely deflated, what that could translate to is that the cuff in the endotracheal tube has deflated. And so it's a good tactile feel of whether the cuff is up and whether the pressure is high enough. Now, some of the endotracheal tubes that you'll see in intensive care are very special. They have a third line that comes out. This is that yellow port. And this is something called a subglottic suction port. Now, as I mentioned, with the tube cuff up, you will have secretion sitting just on top of the cuff. What this endotracheal subglottic suction port does is that you can suction out this port, and the opening to this port is sitting just above the level of the cuff, and therefore all those secretions can be suctioned out and then discarded. Now, we talked about the fact that having the cuff up prevents aspiration, but the honest truth is, however good a cuff is, there will always be a little leak of secretions down the sides of the cuff and then into the lungs, the so-called microaspirations. And there is some evidence that by regularly suctioning the subglottic port, you can reduce the risk of microaspirations and therefore the risk of ventilator-associated pneumonias. Now, the final important thing to know about endotracheal tubes is that they come in different sizes. You'll hear people talking about a size 7 tube, a size 8 tube, a size 8.5 tube, a size 9 tube. What they're referring to is the internal diameter of the tube. And you can see here the cross-section of the tube in the top right-hand side of the picture. This particular one is an 8.5 tube because it's an 8.5 millimeter diameter inner tube area. And this is the tube through which all of the ventilator gas goes. So you might ask, what's the relevance of that? Why bother with a big tube or a small tube? And the reason for this is quite complicated, but essentially comes down to one of pressure and resistance. The bigger the tube, the less resistance there is. So when the patient is exhaling, if you're exhaling through a large tube, it's much easier for the gas to escape compared to if you go through a small tube or a straw. Also, when you're forcing gas into the lungs, say you want to push 500 mils of gas in, pushing it through a large diameter tube means that you need a much lower pressure than if you use a much smaller tube. And you know intuitively that that's the right thing, because if you imagine a garden hose, you switch it on and it just dribbles out some water. If you partially occlude the end of the tube with your finger, suddenly the water just starts to spray out with a much higher pressure. The same is true of ventilator gas. You want to try and reduce the pressures that the lung sees. The higher the pressure, the higher the chance that the lungs may develop a pneumothorax. Again, it's like blowing up a balloon. If you blow it up with a lot of pressure, a lot of force, you might blow that balloon, whereas if you blow it up slowly, there's much less risk of the lungs being damaged. And that's what we call barotrauma, and you'll hear a lot more about that a little later in the series. So when you receive a patient, the first question that you must ask is it in the right place? Now, in order to know what the right place is, have a look at the cross-section that you see on the extreme left of this slide. You can see here the endotracheal tube going down and sitting in the trachea below the level of the vocal cords. Just behind the trachea, you can see there's the esophagus. What you don't want is for the tube to sit in the esophagus and cause what we call an esophageal intubation. Because if you imagine air being pushed down into the esophagus, that's only going to go into the stomach, nothing is going to go into the lungs, and the patient will rapidly become hypoxic. An esophageal intubation is usually detected at the time of intubation or shortly thereafter. However, occasionally, when you move a patient from the trolley onto the intensive care bed, they can dislodge. So it is really important to always be conscious of patients self-extubating and potentially developing an esophageal intubation, especially if they cough as they're being moved, or if they're just coughing naturally. They can cough that tube out and then it can go down into the esophagus. So, the most important thing to look at to confirm the position of an endotracheal tube and to confirm that it is sitting in the lungs, in the trachea, is looking at the end tidal CO2. If you look at the monitor on the right hand side of the screen, the bottom waveform, the white rectangles that you see there, that is the end tidal trace. Every single intubated patient should have end tidal monitoring with a trace. Be reassured if you see a good normal trace like you see with that monitor there, the tube is most likely in the trachea. Now there are some slight variations to that, but for the most part you can be reassured that this patient is being ventilated and the lungs are seeing the ventilator gas and exhaling that gas into the ventilator again. What it doesn't tell you is how far that tube has gone. Where you want it to be sitting, if you look at the picture again on the left, is you want it to be sitting just at the trachea, just below the vocal cords. However, if you push that tube down too far, it is going to go until the point of the bifurcation of the trachea into the left and right main bronchus, and then it could go into either of those. Commonly, it goes into the right main bronchus. Just anatomically, the way it sits, it's just more likely for it to follow that route. Now, by getting what we call an endobronchial intubation, you can collapse down the other side of the lung, which is not getting gas, and therefore these patients can very rapidly desaturate. So after you've looked for an end tidal CO2, confirming that the tube is in either the trachea or the bronchus, you then want to have a listen to the chest to make sure you've got equal air entry. And what equal air entry suggests is that there is gas going into both the left and right main bronchus equally, and therefore it is likely that the tube is sitting above the level of the carina. Now, it is important when you're listening to the chest to listen into the armpits, because this catches the upper lobes. And sometimes you can get the right upper lobe coming off the trachea as opposed to coming off the right main bronchus. And very occasionally, that can cause the right upper lobe to collapse. Similarly, if you've got a right main bronchus intubation, an endobronchial intubation, you will not hear great air entry, and the most sensitive place to hear that is in the armpit in the left side. So listen in all quadrants as you would normally do, but pay particular attention to the armpits in both sides. If you hear quiet air entry, it might mean that the tube is in too far, or it could be relating to the underlying pathology that the patient was intubated for. Now, after you've done your bedside assessments of the patient, it is important to get a chest x-ray very quickly for these patients who have been intubated, because you need to radiographically confirm the position of the tube, specifically where the end of the tube is. Now, the extreme left picture shows the perfect position of the endotracheal tube. You can see the carina has been blown up, and that red angle is the carina that you see, and the lines show the level of the endotracheal tube. Ideally, the endotracheal tube should sit 1 to 3 centimeters above the level of the carina. A quick way to eyeball that is that the endotracheal tube should be sitting in between the heads of the clavicles. If it's sitting above the head of the clavicles, it might be that the tube is out too far. If it's sitting too close to the carina, then it's obviously in too far. The radiograph in the middle is a really important one, and it shows the endotracheal tube going down the trachea and then veering off to the right-hand side. And this is the classic right-sided endobronchial intubation. And you can see that there's white all over the left-hand side, and the cardiac silhouette that you'd normally see of the right atrium and the right ventricle has completely disappeared. That's because the left lung has completely collapsed. The heart has been pulled over towards the left, and you can see that there's rib crowding. And also, if you look at the right upper zone, the right upper lobe is collapsed as well. So the only bits that are being aerated here is the right middle and lower lobes. And this patient will likely desaturate quite quickly. And the remedy for this is to pull that endotracheal tube back so that it's sitting 1 to 3 centimeters from the carina. The final thing that's really important to look for when checking a radiograph for a patient who's been intubated is a pneumothorax. As we alluded to before, any patient with positive pressure ventilation runs the risk of developing a pneumothorax. And you can see here a lung edge, as the right side has a pneumothorax. And there's also some surgical emphysema that you can see, and also some mediastinal air as well. The important thing about pneumothoraces in patients with positive pressure ventilation is that they are at very, very high risk of developing a tension pneumothorax. As such, if you see a pneumothorax, the patient should have a chest drain. The pneumothorax doesn't necessarily tension rapidly. They can occur over a period of time, and so it is important to always be vigilant of pneumothoraces, and every time you assess a patient who's intubated and ventilated, have it in the back of your mind to make sure that you rule one out. Very occasionally, you can be caught out. So when you're receiving a patient who's been intubated either in in A&E or in theatres, and they come to the intensive care, you as the junior are likely to be the person who receives the patient, clerks them in, and gets the paperwork done. Now, when you're receiving a patient, thinking specifically about the airway, it is important to always go through this checklist in your mind. The first thing is always to check for an end-tidal CO2. Because as we said before, an end-tidal CO2 confirms that the tube is sitting in either the trachea or the bronchus. You won't know which without listening and without looking at a chest x-ray, but it tells you that at least you're getting oxygen into the lungs. Then it's worth checking the length of the tube at the level of the lips or the teeth. This is really important because if it's in too far, it's more likely that you need to think about an endobronchial intubation, or if it's not in far enough, again, there's a chance that it might get coughed out, or it might knock out when you're transferring the patient, and therefore the patient might extubate accidentally. For a normal adult, the length of the tube at the level of the lips should be between 19 and 24. Now, it obviously varies depending upon the height of the patient, the length of the neck, and whether the tube is curled at the back of the mouth. However, if you see patients with an endotracheal tube that's sitting at 16 or 14 centimeters at the lips, always think to yourself, has this tube come out too far? Similarly, if you see a tube that's in at 26, 28 centimetres, again, think to yourself, has this tube gone too far in? Is this an endobronchial intubation, or is it sitting too close to the carina? Again, you'll only be able to confirm that through a combination of auscultation and chest radiograph, but it just increases the index of suspicion. You will be surprised how often these tubes move in and out during transfer, rolling of patients coughing and so on, so always be cognizant of that length. When you're listening to the lungs, the two things that you need to really think about when thinking specifically about the endotracheal tube is whether it's an endobronchial intubation, i.e. there's asymmetrical air entry, and whether there's a pneumothorax. Obviously, when assessing the lungs, you're also looking for other things, thinking about the B, C, D, E, F, G, H, I of the patient, which we'll go through in different lectures, and I've introduced in the first talk that's on my video on my playlist. The final thing that's important to get from the person who intubated the patient is the grade of intubation. You will hear a lot about the grade of intubation. Essentially, this is a way for us as doctors to communicate how easy or difficult it was to intubate someone. Generally speaking, a patient with a 2B, a grade 3 or a grade 4 intubation is classed as a difficult intubation. Now, in order to understand exactly what it is, imagine that you look inside the mouth and you look beyond the level of the tongue. And what you will see is what you should hopefully get as a grade 1 intubation, which you see in the top picture there. You see the epiglottis, you see the arytenoids, you see the vocal cords. And you can see the full glottic opening, and that is the trachea that you're seeing there. So that is what we call a grade 1 intubation. If you see that, then you can put a tube in easily. With a grade 2 view, you're not seeing the whole glottic opening, you're just seeing a little bit of it. And with a grade 2A, again, you're seeing most of it. So you're actually not that worried. You could very easily get a tube in or a bougie into this. A grade 2B, you're just seeing a little bit of the glottic opening, but here it's starting to get a little bit more difficult to actually see where the tube has got to go. And finally, with a grade 3 intubation, all you're seeing is the epiglottis. You can't see the glottic opening, and therefore, when you pass the tube, you're not quite sure whether it's gone into the trachea through the vocal cords, or whether it's flipped down and gone into the esophagus, which is literally lying just behind. So it is important to find out from the person handing over to you what the grade of intubation is and to document it. If it is a difficult intubation, either a grade 2B, a grade 3 or a grade 4 intubation, then that must be highlighted and there must be alerts put on the patient and around the bed space so that if there is an accidental extubation, everyone there knows that a very senior anaesthetist or intensivist needs to intubate that patient because they are difficult. Now, when you do your daily assessment of the patient, it's really important to go through it methodically. And throughout the series of videos that I'll be doing, I'll be going through the methodical management of each different aspect, starting off from airway, going to breathing, circulation, and so on. In terms of the daily assessment of the endotracheal tube, the question you need to ask yourself is whether they need it, what the level of the tube is at the lips and the teeth, and finally, what the cuff pressure is. A high cuff pressure is potentially a dangerous thing because what this does is it risks there being necrosis of the tube at the level of the trachea, and that can cause tracheal stenosis. Similarly, if the pressure is too low, that might be indicating a cuff leak, and therefore there may be a rip in the cuff, or there may be air leaking around the tube, and therefore they're getting inadequate ventilation. Now, When we think about troubleshooting, there are three main things that you as the junior will get called for problems with endotracheal tubes. The first is a cuff leak. If you take the picture on the left-hand side, you can see where the cuff should be sitting. It should be sitting at the level of the below the level of the vocal cords in the trachea. And if it's fully inflated, there should be no gas leaking out into the oropharynx. However, if a tear or a rip occurs in the cuff, what will happen is that it deflates and therefore gas will escape around the edges. Now, the way in which to know whether the cuff has got enough air in is to have a feel and a look of the pilot balloon, which you can see here is labelled the cuff inflating tube. Just feel that. If you feel that there's air in there, there's likely to be air in the endotracheal tube cuff at the level of the trachea. And therefore, there is something else wrong. If it's deflated, put some more air in, and again, if it deflates, you know that there is a tear in the cuff, and therefore the whole endotracheal tube needs to be changed. The other thing that can happen is that the tube can migrate out. And if you look at the right-hand picture, you can see that the tube is sitting, the cuff is sitting just above the level of the vocal cords. So the cuff itself is intact, it can hold air, so the pilot balloon will feel like there's air in it. However, there's a leak of air because the patient may have coughed the tube out, or it may have moved out as the patient was being rolled or moved, and therefore it's sitting half in the trachea, half out. This patient is at very high risk of self-extubating and therefore needs very rapidly for this tube to be advanced into the trachea. Again, you need to call for help early. So, if you've got a patient with a cuff leak, this needs to be addressed by a senior airway trained doctor early, because the risk is either that you're going to aspirate, because remember that cuff is the only thing that's there to prevent oropharyngeal secretions from going down into the lungs. And similarly, if it's sitting above the level of the vocal cords, there's a high risk that the patient might extubate and therefore desaturate and could potentially get into serious trouble. So if you hear a cuff leak, stop any NG feed, aspirate anything from the stomach to try and reduce the risk of aspiration, and call for a doctor immediately who can re-intubate this patient either with a new tube or by advancing the existing tube below the level of the cords if it is simply a matter of the tube having come out too far. The next problem is that the nurse might say that the patient intermittently is requiring high airway pressures or continuously requiring much higher airway pressures. Now, there's a variety of different things that could be causing this, and this is by no means a comprehensive list. But one of the few things that you can deal with is whether the patient is biting down on the tube. If you imagine where the tube is, you can see on the top picture the teeth are sitting just around the tube, and if the patient becomes light, they may start to bite on the tube, thus occluding it. And if you remember what we talked about with the diameters of the tube, the smaller the diameter, the higher the pressure, and that's what the ventilator might be detecting, because the caliber of the tube is reduced because the patient's biting down. There's a variety of ways to manage this. One could be to sedate the patient more and therefore reduce the amount of the awareness of the patient and therefore the chances of them biting down on the tube. The other thing is to put in a bite block, and you see some examples of these bite blocks in the right-hand top picture. These bite blocks sit between the molar teeth and the side of the mouth and allow the mouth to remain open. The patient can't bite down on the tube, and so it's much safer. And actually these are great for nurses then to provide mouth care for patients as well. An important cause of high airway pressures could be that the endotracheal tube has moved down from the tracheal position that it should be in, down into one of the bronchi. And therefore, because the bronchi have much smaller calibers, now you're ventilating only one lung, suddenly the pressures start to go up. And so if you do see the pressures go up, always think about whether the tube has moved in too far and developed an endobronchial intubation. The way to find out is by listening to the chest and by doing a chest x-ray. The final thing is, the patients may have had this tube in, whether it's an endotracheal tube or what you can see in the bottom right picture there, tracheostomy. If it's been sitting there for a long time, or if the patient's got a lot of infection or secretions, those secretions may start to coat the endotracheal tube, they may start to block off the end of the endotracheal tube and therefore increase the resistance. And so with a tracheostomy, sometimes you need to change the tracheostomy, either the inner cannula or the whole tracheostomy itself. We'll go through that in a lot more detail in the next video. Or it might be the endotracheal tube has got a lot of secretions, and sometimes passing a suction catheter and putting some saline down the endotracheal tube just to clear and loosen up any secretions might be all that's needed. But it's important to really have a look through all of the different options that could be causing a high airway pressure. Of course, there are other things patient-specific, such as if they've developed bronchospasm or whether they've collapsed a lobe of a lung due to secretions, or tumours causing compression of the main airways. All of these things could also increase the pressure, but thinking just about the tube, these are the three important things for you as a junior to rule out and to escalate to a senior early. The final thing, and probably the thing that most juniors are worried about, is the accidental extubation because you don't have airway skills. And I want to emphasize the fact that you do not need airway skills to be able to manage a patient who has accidentally self-extubated. Now, of course, these patients are at high risk. However, there are simple things that you can do to manage the airway until a senior comes along and re-intubates the patient. The first thing is to know when a patient has had an accidental extubation. And I keep emphasizing this, but every patient should have end-tidal CO2 monitoring. And you can see the graph in the bottom there of this slide, where you can see two normal rectangles of the end-tidal CO2, and then suddenly it goes flat. And the reason for it suddenly going flat is that the tube has suddenly come out of the trachea and there is no longer exhaled air with carbon dioxide coming through the tube and into the ventilator to be detected. And this patient has therefore self-extubated. Always check with the nurse and always look at the clinical situation, because sometimes end-tidal CO2 monitors recalibrate, and when they recalibrate you see this straight line for a short period. However, if you see that the end-tidal is gone, always assume that the patient is self-extubated and manage the patient appropriately. This might mean putting a Goodell airway in and using a bag valve mask technique, as you can see the nurse doing in the picture above. This is something that all BLS and ALS providers have been trained with. The other option is, if the patient is unconscious or heavily sedated, you can put an eye gel down, and these are good temporizing measures until someone who is more airway trained can come along and take control of the situation. The key thing to emphasize is do not panic. Just because a tube has gone out doesn't mean that you can't oxygenate that patient, and that is the priority in these patients. As an aside, it's always important, if the patient's airway it becomes unsecured for whatever reason, be it a cuff leak or if the patient has extubated, always switch off the feed and aspirate as much of the feed as you can, because what you do not want is for that gastric contents to then go into the lungs and cause an aspiration pneumonia. Now, I hope that talk really demystifies some of the aspects of managing a patient with an endotracheal tube. I hope that you'll understand a little bit about when to call for an intubation, when to escalate a patient who is being admitted to the intensive care as a watch and wait. how to assess an intubated patient, especially when they first come onto the unit, where you might be the first person to look at that patient. And also some common troubleshooting of problems that can happen with endotracheal tubes. By no means is this talk meant to make you an expert in managing airways and managing intubated patients, but these are the basics of how you deal with an endotracheal tube and how you deal with an intubated patient. And if you hold true to these values and these steps when assessing a patient, you will be safe with a patient, and hopefully after seeing this video, and the next time you manage a patient who's been intubated, you won't feel that same level of trepidation because you know exactly what's going on, what the process of an intubation is, and what a normal intubation is. If you like this video and you found it helpful, please do subscribe to my videos, like them, and if you could leave a comment, that would be fantastic, just to help build this YouTube channel up. I really appreciate all your support. Thank you so much, and all the best.